Welcome to those that are just joining. This is the Scottsdale Institute presentation, Improving Quality of Care by Streamlining Access to Information, presented by Fletcher Allen Healthcare. And I'd like to now turn it over to Chuck Podesta, Senior Vice President and Chief Information Officer at Fletcher Allen Healthcare, and also John McConnell, Senior Web Developer at Fletcher Allen. And Fletcher Allen, as many of you may know, is the teaching hospital in alliance with the University of Vermont.
A little bit about the agenda. I'm going to briefly describe Fletcher Allen Healthcare for those of you who are unfamiliar with Fletcher Allen. A little bit about PRISM overview. When I say PRISM, that's our Epic Electronic Health Record Installation implementation. We did a contest, a naming contest. It stands for Patient Record Information Systems Management. So you hear PRISM, that's interchangeable with Epic. So I'll just briefly talk about some of the key drivers, what we looked like before we deployed the Epic or PRISM system, and then John's going to take over and talk about the state of the system reloaded. Kind of walk through the implementation strategy, user reaction, both positive and not so positive, and lessons learned that will hopefully be helpful to you as well. We're the only academic medical center in Vermont. We are one of 14 healthcare facilities. We're surrounded by 13 other community hospitals, 8 of which are critical access hospitals. So it's a kind of a unique situation from the standpoint of a state. Our market also extends into northern New York as well. About 12% of our revenue comes from upstate New York business. We're the only tertiary quaternary care facility in Vermont and in northern New York as well, so we get all that care. You can see we have 6,700 employees. Our faculty practice is quite large, along with the total medical staff. When I say faculty practice, those are the employed positions. We also have mid-levels and PAs, 147 of those. We are linked to the University of Vermont Medical School and the University of Vermont, and we do have residency programs and medical student programs in all the specialties. Almost 1,700 nurses, about a little over 562 beds. You can see the medical student number, nursing and health science students. We also, as part of the UVM Medical School, there's also a large nursing school as well. And in the community, in the state of Vermont, we do about $8.7 million in charity care on an annual basis. Our mission is to improve the health of the people in the communities we serve by integrating patient care, education, and research in a caring environment. As part of that mission, our focus is on rural healthcare, and you can see on the vision is the Fletcher Allen Healthcare is committed to being a national model for the delivery of high-quality academic healthcare for a rural region. As opposed to other parts of the country, we're not in real competition with our community hospital family. We do focus hard on keeping the primary and secondary care in the communities that those community hospitals serve and their providers as well. Our role is really to work with them, ensuring a high-quality primary and secondary care, but also making sure that they have a tertiary and quaternary care delivery system that they can provide in their communities. It's a nice symbiotic relationship, I think, where you don't see that as much in urban areas where there's quite a bit of competition for not only the tertiary care but also the primary and secondary care. Some of the key drivers for PRISM or the Epic implementation, we did a large selection a few years back and narrowed it down to Epic and was able to complete an agreement. We started the project we've got CON approval in the state of Vermont. Anything over $3 million requires a CON. So we get CON approval for the project back in April of 2008, and we went live with our first phase, which is all the inpatient modules, including an ED and a pharmacy system, in June of 2009, so about 14 months later from the start. Our goal was really a bunch of reasons, and you can see it bulleted there, really needed to replace antiquated and inadequate systems. So I've got a slide on that. I'll kind of show you our pre-deployment situation. We wanted to have the kind of a quick and consistent access to information from a single point, as well as electronic health record, electronic medical record will do. The medication administration process, we wanted to expedite that. We wanted to also, from a patient safety standpoint, really impact adverse medication interactions and medication problems in general. legibility of information, which gets to the physician order entry or provider order entry piece. Uniform treatment protocols, being able to design order sets and lock those into the system to guide the providers through the treatment process based on best practice, and overall efficiency and cost effectiveness. On the security side, we really wanted, following the HIPAA guidelines and some of the state regulations, wanted to really beef that up from the standpoint of data security and also balance that, though, with accessibility, comply with the HIPAA regulations. Data integrity and quality was important, but then also the VIP and break-the-glass security process, both from a VIP where we could take a little bit more control of the information from a privacy standpoint based on the individual being treated, but then also the break-the-glass aspect of it when somebody does show up in the ED and needs to be cared for, a life and death situation. Some of the other considerations is that we were looking for a robust application mix. Sometimes when you go to a single vendor approach, you've got to give on some of the modules to get the overall functionality. We felt Epic, they are a single database solution, but that their modules, their individual modules, were as good as, if not better than, some of the best-of-breed modules that were out there. So I think we've got kind of the best of both worlds, the integration plus the best-of-breed functionality. We wanted an open and flexible architecture, and Epic certainly provides that with the cache system. Robust and stable technology. Epic's been around for a long time, a very mature product, both on the inpatient and ambulatory side. Scalability, which we know Epic is in very large organizations. Clinical workflow expertise. Again, with Epic, they have a very good track record in computerized provider order entry and just overall clinician acceptance and adoption of the system. Easy to install, deploy, and manage, which, again, is easier said than done no matter what system that you have in place, but Epic did have a nice program for that. Rapid time to solution was another important thing, and I think getting the inpatient organization up in 14 months proved that. Some of our pre-deployment, you can see we had something called Maples, which is a window-based system, homegrown. It was a read-only source of clinical data, been around here for many, many, many years, known kind of throughout Vermont, hence the name Maple, but that's something that we definitely wanted to sunset at some point. We had something called HIS, H-I-S-S, was a IBM mainframe system, and that also hosted clinical data as well. Again, homegrown, very old system. I think it was written in assembler language, actually. That's something we certainly wanted to sunset as well. A T system, which was in the ED, worked pretty well for the ED, but wasn't integrated with any other system, whether it was HIS, Maple, or anything else we had. Pisces product in the anesthesia OR and pre-op, again, kind of a standalone, best-of-breed boutique system. McKesson PACS, which we maintain, we still have. ImageCast, which is GE IDX product for RAS, and SoftMed for transcription. So you see we had a kind of a mixed bag from a clinical perspective, a lot of interfacing. We have a Cloverleaf interface engine, but not, from a clinician's point of view, many, many desktop icons to be going in and out of on a regular basis.
So Chuck has done a great job and laid out the vision and sort of where we are today. What I wanted to do now was drill down a little bit into a particular portion of the PRISM architecture, specifically what we had to do with our desktop computers in our clinical environment to prepare for PRISM and to ease the burden on doctors and nurses and clinical staff in getting to patient data quickly, as seamlessly as possible, and with a minimum amount of password entry. So let me start by sort of explaining where we were prior to the PRISM project. We had 3 flavors of computers in use in the clinical environment at Fletcher Allen prior to PRISM. We had sort of a classic single-user desktop. This is very much what probably most of you are familiar with, Windows XP, Microsoft Office. We used Symantec's Ghost imaging software to deploy machines, one user logged on at a time, and then additional clinical software installed by a field technician, usually at the point the machine was installed, and that varied from department to department, location to location. We had something we called the kiosk desktop. This was used primarily in high-traffic areas, nursing stations, reading rooms, the lab, other areas like that, where you might have more than one person using the computer in the same shift. having to log in with their own Windows account, waiting for the logon process to complete, and then start up their applications was onerous. So we used a variation on the Microsoft Steady State Computing platform so that when a doctor or nurse walks up to one of these kiosks, it's already at the desktop, and they can click the icon and start their application. While this functioned well and it speeded their access, it had a lot of security and usability issues associated with it that we wanted to resolve. The third flavor was very similar to the kiosk, but it was reserved for very specific places like operating rooms and a few other key locations where they had very specific clinical workflow needs and requirements. In almost every case, these are also desktops that there's no patient access. They're not sitting in a hallway or at a nursing station. They're usually in a locked room or a place where only clinical staff can access them. That's sort of a background of where we were. Let me move into some of the decisions we made and where we've ended up. As Chuck mentioned, Maple, HIS were old sort of homegrown applications. They are in the process of being decommissioned. I think HIS pretty much is, and Maple will be very shortly. And T-System, while it was a perfectly functional system, has been decommissioned in favor of the PRISM platform. However, some of our best-of-breed applications, like our PACS, like the PISIS Office Suite, like ImageCast from GE, we are going to be continuing to use for the foreseeable future. So we wanted to have some way to better integrate those systems, which are very important to the specialties that use them, with the new EHR. So we basically took an approach where we decided to use Citrix Password Manager to provide a single sign-on approach or an automated application login for that aspect, and then to keep the patient data synchronized on the screen for the clinical user. We use the Carefx Fusion FX product to provide what we call context switching, so that if I change the patient that I have up in Epic, for instance, then the ImageCast application will automatically move to the same patient. We had about 1,500 of these kiosk-style desktops deployed when we started. We basically decided that we were going to use WISE terminal thin clients in many locations, exam rooms, bedside areas, where the application access that was needed was primarily going to be PRISM, which we deliver over Citrix XenApp. And these provide extremely fast logon for the clinical user and basically are very much pure clinical machine. There's really very little else you can do with those other than run PRISM and a few other clinical applications. We additionally implemented a number of what we've referred to as both cows and wows, either computers on wheels or workstations on wheels, using a Windows XP embedded platform with a custom card configuration that are used heavily in places like the emergency department, where they can be wheeled from one room to another using a wireless network access and a battery. And a few tablet devices that some doctors are using and carrying with them from their office, as they go out onto the floor and make rounds. So altogether, those three classifications come to about 400 devices today. We anticipate that number continuing to go up, probably primarily with the WISE thin clients. We then had about 1,100 shared desktop workstations that replaced the kiosk PCs. And we made a couple of strategic decisions that were probably a little controversial when we came up with it. We decided that everyone was going to have to log into Windows. There would be no shared account always logged into the desktop. But we did a lot of work to speed the Windows logon to the greatest degree possible. What our benchmarking showed when we were done was that the first time a clinical user logged on, it was about 45 seconds to log on, and subsequent logons were 10 to 15 seconds. I'm not going to lie to you, I think our doctors would still like it to be faster, but that was our first shot out of the gate. We then included the single sign-on Citrix Password Manager and Carefx Fusion FX products on that desktop. So no matter who the clinical user was, when they log on to one of these machines, they're going to get the benefit of the context enablement and the automatic application login. In terms of the desktop, we actually built the first prototype desktop in December of 2008. We actually had a pilot going by the end of 2008, early 2009, and I think we actually began deploying these in the March-April timeframe. We had a lot of guys rolling out a lot of machines this spring. There were 6 core team members in IS, And then we had a number of clinical experts who work in IS but who work very closely with the various departments. Most of this centered around the Carefx context enablement because we had to have a very good understanding of the clinical workflows that we were going to be developing toward as we did the context enablement. So for instance, we worked very closely with the lady who is an expert in the PISA software. We've worked very closely with our radiology staff and so forth. And we basically began development on that in the December time frame, and we were ready for rollout on May 18th. So we were able to turn that around very quickly. We context-enabled a total of 8 applications. One of those was the Epic application, which was, by the way, the easiest because Epic is a native CCAL compliant application, so the amount of work that had to be done there was minor. And we finished on budget, and we were ready for go-live, which was our target. So it went very smoothly. And this is primarily today just the inpatient areas, although we do anticipate that when we get into our ambulatory rollout, some of these same applications will be leveraged there as well. I always allow myself one war story. So here comes my customer testimonial. About 2 weeks after we went live with PRISM, I got a call from one of our service center representatives who had a very unhappy user on the line. She worked in our pathology and lab medicine area and had been using PRISM quite well and was calling to complain that one of the lab applications that she used wasn't keeping up on the same patient like the other applications did. And of course, the lab application is one we were actually looking to sunset, so we didn't develop context enablement for that. So while she was not happy to hear that we wouldn't be context enabling that application, I took it as a positive sign that it must be working well on most occasions for users to want it in other areas. Some things we learned. Overall, things went very smoothly, but the key thing to remember is that probably what saved us a lot of time is we actually had the Carefx project team come on site for 3 days and work directly with the clinical experts up at the hospital as they went through their workflow and screenshotted everything that they did and compiled that into a functional description. Most of these clinical applications, as I'm sure you know, are extremely complex. The users are extremely sophisticated, and we needed to make sure that we were capturing all the right information about how the application was used so that we could guarantee that it performed as expected. And we worked very closely to produce that functional specification and get sign-off from the clinical experts before we began formal development. The other thing I'll say was very important in helping us to be successful was we had extremely strong executive and clinical sponsorship. Chuck was behind us all the way, getting the word out to various doctors and departments that this was coming. We also had a great level of involvement from our chair of anesthesiology, and he had his staff very focused on this, which really enabled us to not only have that be successful, but to have him communicate that success to his peers. So that really smoothed the way. Single sign-on and context enablement are these sort of nebulous terms that mean different things to different people. One of the things that we could have done better would have been to have demoed the technology to more of these departments before we went live, because invariably when we did do it, the reaction was, oh, that makes sense. And then a lot of the fear, uncertainty, and doubt just went away. So if I could go back in my time machine, I would probably have booked a lot more of those meetings sooner than we did. Where do we go from here? Well, right now we're live with 6 of those 8 applications. We are actually piloting right now on our radiology diagnostic imaging workstations. The pilot is ongoing now, and I think they're working on getting their rollout dates fixed today. And then we're probably going to be looking at including other applications based on need and demand. It's a little bit of a moving target right now because Epic is such a sweeping effort. We're very focused on the ambulatory rollout. It may be a few months before those options crystallize for us, but I do anticipate that there will be other applications added down the road, particularly when we go live with ambulatory. I think we'll probably find some applications maybe we didn't really realize we had or didn't understand the impact of, and we'll be then including them at that point. And of course, as I mentioned, the new single sign-on desktops and workflows can always use refinement and improvement. I mentioned the log-on time being faster, but still not fast enough. I'm sure that's an area we'll revisit, as well as many other of the technology tuning and tweaks that goes along with any large-scale rollout.
Okay, well, Chuck and John, we want to thank you both very much.
Sure, no
That's
problem.
fine. Our emails are on the presentation. Feel free to reach out to us, anybody who would like to ask a question afterwards.
Thank you so much, and everyone have a great day, and thanks for coming today.